4 articles which we feel will go through the gamut of the presentation of SI joint disease and its treatment and some outcomes and some novel surgical techniques, which we hope will promote interest and spark some discussion. The first article is by Dr. Marcus Stevens, our chief resident. Please go ahead, Marcus, with your presentation.
Thanks, Dr. Kazemi. So to kind of kick things off, we'll start by reviewing an article that really gives us an idea of why as spine surgeons do we actually, concern ourselves with the SI joint and its pathology. So I'm going to review an article entitled Incidence, Diagnosis, and Management of Sacroiliitis After Spinal Surgery, a Systematic Review of the Literature. This was published by a group in Italy in Musculoskeletal Medicine. Okay, so in their background, they briefly discuss some of the causes of low back pain after a spinal fusion. And we know from experience they're manifold, most commonly being adjacent segment disease. There's pseudoarthrosis, and a little less commonly now, you see iliac crest graft harvesting. And then the focus of the article is discussing sacroiliac joint dysfunction. And according to some of their findings, symptoms are actually due to SI joint dysfunction and pain. So we also know from a construct standpoint that when the sacrum is involved, usually meaning S1, the SI joint is the next most distal joint to our construct. So this study reviewed the literature, incidence, diagnosis, and management of SI joint pain, specifically after a spinal arthrodesis. Okay. So the methods that they used, they looked at Google Scholar, Embase, Medline, PubMed, and they initially found over 600 articles. And they specifically looked at topics that keywords such as lumbosacral fusion, lumbosacral arthrodesis, spinal fusion, and sacroiliac joint pain. After they removed all the duplicates, they took off a few articles. Then they had 2 independent authors that actually looked at every single article and screened the titles as well as the abstracts. And those abstracts that were selected, the English ones were read completely, and they applied their inclusion criteria, which mainly included incidence, diagnosis, and management of sacroiliac joint disease after spinal fusion. And then I wanted to just make sure we all saw that they excluded any ex vivo and any biomechanical studies. So these were all actual clinical studies in vivo with actual patients here. And they whittled it down to about 13 articles. Okay, so once again, there were 13 articles that were reviewed in this study. Levels of evidence weren't all that strong. There were only 2 with level 2, 3 level 3 evidence studies, and 4 level 4. They cumulatively, there were 1,279 patients that actually underwent some type of a lumbar or a lumbar sacral fusion. And they found that the incidence of SI joint pain after spine surgery was 37%, plus or minus 28.5%. And I just pulled a few of the different types of results that I thought were important from the article. So they looked at the reported surgical approaches in each one of these studies that were offered. And foremost, the most common approach was a posterior only approach, which was 82.3% of patients. There were a few that underwent lateral, which was the next most common at 3.4%, just a small amount in anterior. And then posterolateral was reported in some of these articles. And by that, I'm thinking you could probably group the posterolateral and posterior together as far as what they did. And then with levels of fusion, these are just what was reported with what they had to work with. And there were 516 one-level fusions, 77 two-level fusions, and 60 patients underwent 3 or more levels of fusion. Okay, this is another kind of key point that I thought was important in this article. So they also looked at the modality that was used in order to actually evaluate the sacroiliac joint pain after the spinal fusion. So only 37% of the patients that were reported underwent both provocative maneuvers or some type of a SI joint block. And then once again, 37% of patients that were reported, the article said that they underwent intra-articular injections, which we know is kind of the gold standard, if you will, or the preferred method for evaluating SI joint pain and dysfunction. 23.1% of the patients underwent some type of a provocative testing, which once we're all familiar with that, and I think we'll discuss that a little bit later in some talks later today. And then also 21% underwent SPECT, 13% X-ray, then you had CT and MRI with 9.4 and 2% respectively. Okay, so a few discussion points that I wanted to highlight that they talked about in their article is one, that sacroiliitis increased with the number of levels fused. So when you include the sacrum, and my understanding of that, they didn't specify, but it would be including S1 in the construct as opposed to actually doing some type of a sacropelvic fixation. When you include the sacrum, it did show to increase the incidence of SI joint dysfunction. So if you stop at L5, it sounds like you're less likely to have SI joint dysfunction than stopping at S1. And this brings about the question, should we do more fusions across the SI joint? We also found that bone graft harvesting caused a significant amount of postoperative SI joint pain. And there was one study that actually looked at surgery versus no surgery just for patients that underwent lumbosacral fusion versus patients that did not undergo lumbosacral fusion, both which had SI joint pain. And they found that SI joint patients that underwent surgery actually had, all of them had SI joint dysfunction or some type of pain after surgery versus 64% of the patients that had never undergone surgery. So surgery in itself, and I think this is another big point for us to discuss as spine surgeons, but lumbosacral fusion itself is a risk factor for actually having advanced degeneration of your SI joint. And we should take that into consideration. Okay, so they concluded that SI joint degeneration is probably due to increased impact load after the fusion, which makes sense. I think that just going the opposite direction, we see that with adjacent segment disease all the time. And I won't spend too much time on the biomechanics of that because I think it's pretty well understood for adjacent segment disease. And also, they looked at some other factors that may affect the SI joint pain after fusion. So BMI was a big one. And then also one of the studies that commented on sacropelvic fixation being another cause of SI joint pain after a fusion. And then there was one paper that looked at the etiology of the degenerative disease in the lumbar spine, which was the indication for the surgery. And they found that spinal stenosis patients seem to have an increased risk of SI joint pain after surgery. Another important point that I wanted to talk about was that out of all these studies, only 471 patients, or 44.1% of patients, actually had an SI joint injection. And we know that this typically is one of the best ways to test for actual SI joint dysfunction, because sometimes it can be a rather cryptic diagnosis if you're not careful. Okay, a few more discussion points. They briefly touched on some other non-surgical treatments, which we all know physical therapy helps. Pelvic belts, which can reduce the SI joint movement by approximately 30%. And also there was a study they looked at that discussed platelet-rich plasma. So This was the PROBE study, and this was actually in a prospective randomized open blinded endpoint. That's the acronym study. They had two groups with approximately 40 patients. The first group had lidocaine and methylprednisolone injections. The second group actually had ultrasound guided injections of the PRP, and they found that the PRP group at follow-up actually had lower levels of pain intensity of the SI joint. And then also with non-surgical or non-fusion techniques, there was the neuroaugmentation. So there was a group that looked at SI joint pain post-arthrodesis in two different patients. And these patients got 1 week of stimulation at S3 followed by a neuroprosthesis. And so those patients actually had 60% pain relief at follow-up. And this is just an example of the pelvic belt. Okay, and then finally, there aren't a whole lot of studies that actually look at SI joint pain and after a spinal fusion as far as large studies, but they did touch on the iFuse, which I'm sure by now we're all familiar with. And this was a multi-center randomized control prospective study that I'm sure we all are familiar with, but they looked at patients that did not undergo surgery for SI joint fusion, and then patients that underwent the SI joint fusion with the iFuse product. And they saw that 81.4% of these patients had better pain relief. And this is just an example of the iFuse product by SI Bone. Okay. And then lastly, they touched on some limitations. As we kind of concluded earlier, the majority of the studies were level 3 and 4 evidence. The evaluation of the SI joint pain was very heterogeneous throughout all of the different studies. And we saw that also the evaluation, most of the evaluations didn't include an actual SI joint injection. So there was some bias with that. And then also there was very minimal long-term follow-up. So that's all I have. And thank you all for listening. We can open it now for some discussion.
Yeah, thank you, Marcus. That was a good starting paper to get us kind of into the groove with respect to understanding this diagnosis and its relation to spinal surgery, to lumbosacral and spine surgery and above. It's really interesting to me. I mean, I think it makes a lot of sense to consider the SI joint as the next level down. So it's not surprising to me to view it as adjacent segment disease for lumbosacral fixation. You know, we believe that things happen to the hip after long construct spine surgery. So why wouldn't the SI joint just be the next logical joint down? The problem, I've always been kind of conflicted, because is pain after surgery in the SI joint, and I've seen it, I'm sure we've always seen it, we have all seen it, is it because of adjacent segment disease? Is it because the original SI joint pain is unmasked because you've treated original spinal disease further up? Is it because, as somebody suggested, if you take somebody with stenosis and they have neurogenic claudication, and the biomechanics of their mobility is that they stress the SI joint, so does it go hand in hand with spinal disease? Or is it just that these people have degenerative disease across the gamut of their joints, of their articular surfaces, and the SI joint is one? Yeah, I'd love to know more. I think that Dr. Chapman made a really good point, and that was the dilemma here for me is diagnosis, and he made the point that there's problems of injections, because sometimes with local anesthetic, it can just spill into the surrounding lumbosacral fascia. And what does that mean?
One thing that they also kind of touched on that I didn't talk about too much was actually looking at some of the spinal pelvic parameters as well. And they noticed that, to kind of comment on the spinal stenosis thing, patients that just had a really vertical looking pelvic tilt often showed increased risk of the SI joint dysfunction, especially after surgery as well. And patients that didn't have that corrected seem to be have a greater incidence of it as well. And I'm wondering, just with the way that patients naturally like to, we've all seen the spinal stenosis patients and how they like to move their back in a way so that their back doesn't hurt. I wonder if that may have something to do with it, and that constant loading on the SI joint may have something to do with it. And like you said, after you decompress their thecal sac and their nerve roots, that pain is just really unmasked as well.
Yeah, that's a really good point.
One of the things about the SI joint that we still haven't truly understood, and this goes back to work that Marvin Tile, Dr. Marv Tile from Toronto, Sunnybrook, one of my mentors at the time, talked about with trauma, how the pelvis, the SI joint, and the lumbar spine is actually a suspension bridge. Everyone thinks it's loaded and shear, but it's not. It's actually a suspension bridge across there if you look at it morphologically. But as the pelvic incidence changes, it may be that the biomechanics is going from a suspension bridge to a cantilever bridge. And as you get a degenerative flat back, you may be doing the same thing. So that may be a difference in the force transmission across the joints that we just haven't looked at. But we've got to look at the morphology, at the biomechanics. And yeah, we absolutely do not understand this SI joint as yet. It's been ignored because we just never really felt it was an issue.
Yeah, it's such a good point. I think, you know, we're becoming more sophisticated. It's definitely a condition. I got to tell you, one of my happiest patients are the patients where we've correctly diagnosed it, correctly treated it, and I have not had happier spine patients than these patients. So there's something to this clearly. I think the last thing I want to point out is that there is a randomized controlled study, the Sylvia trial, looking at the impact of long construct deformity correction on the SI joint, and whether an additional implant to that for an S2AI screw makes a difference or not. It's an interesting study. We're involved in it. So the question about long construct and its impact on the SI joint is hopefully becoming answered. But yeah, thank you, Marcus.
You know, the thing that I find amazing is that it has such little motion, and you think that, you know, just those few degrees of motion, because the stress of the proximal fusion can cause the pain. I mean, you know, for a long time, we just poo-pooed it. We said it doesn't exist. But as you say, that you treat the appropriate patient news and they do so much better. So.
This is, let me just add here. So first of all, Marcus, great review. Thank you for picking this article. This is exactly where I think we have a real opportunity to improve things. Our understanding of the SI joint is insufficient because we've not used the available diagnostic tests, specifically CT scans, to look at air gapping, micromotion of the SI joint, etc. So I thought the title Sacroiliitis is interesting. I may not totally agree with it, but I think we can do a lot better by understanding the big picture of a patient. Do they have connective tissue disease? How good is their myofascial structure? And do they have micromotion? Because what I saw from Marcus's review, there are patients who clearly have a transfer disease, and maybe we can predict those better and then immobilize those joints. So I learned a lot from that article and the presentation, but I think we can do better by kind of categorizing radiographically instability and micromotion of SI joints that then hopefully are also symptomatic.
The thing that was that intrigues me, and this is not transfer disease, but in primary sacroiliac mediated pain, is were we underdiagnosing it previous to the technology of the in the SI or iFuse study, or now because we've got an easy mousetrap to for both surgeons and frankly even pain management proceduralists to do these percutaneous SI fusions, are we overdiagnosing it now? And what's the right balance? And I agree with Jens. It's fertile for real good studies.
Well, thank you. Thank you for those really insightful comments. That leads us nicely to the next article by Dr. Matthew Helton, which actually looks at the treatment and compares conservative versus surgical treatment. Thank you, Matthew. Go ahead.
Hello, everyone. My name is Matthew Helton. I'm one of the PGY4 resident here at UAMS. Let me see if I can show me some mind. There we go. Okay, so I'm giving my presentation today on an article that came out, was published in 2018 in neurosurgery. That's minimally invasive sacroiliac joint fusion, radiofrequency denervation, and conservative management of sacroiliac joint pain, a 6-year comparative case series. This was published out of a group in Valencia, Spain. So the background for this article, for the last 15 years or so, we've really seen an increase in the interest in the sacroiliac joint and looking at what is the cause of issues and how much is it really affecting patients. In a study from Sembrano in 2008, they looked at how often is low back pain not coming from the back. And their answer to this in a retrospective study of clinic patients was 15% of their patients reported, or they actually found that the SI joint was the source of their pain, not necessarily their low back. Another article that my article cites is this article I'll share probably further. So in this article, the authors compared a national registry to compare diseases and look at how much does SI pathology affect the quality of life of patients. And what they found is, that SI joint pain has a huge effect on quality of life. And you can say it's equivalent to things like severe COPD, hip osteoarthritis, knee osteoarthritis, these things that we commonly treat. And so SI joint that has been ignored for a large period of time has really caused a lot of issues with patients. So the methods of study is a retrospective series. They had a strict diagnosis for chronic SI joint pain, greater than 3 months of pain localized to the area without neurologic deficit, greater than 5 on the pain scale, the visual analog scale, greater than 30% on the oscillatory visibility index, a positive Fortin's test, which is basically pain to palpation of the SI joint, and then 3 out of 8 of the positive maneuvers that incite pain in the SI joint. And then after this, they confirmed it with a greater than 50% pain reduction with bupivacaine injection into the SI joint. They excluded patients that had other reasons to have pain, failure of the confirmation test, that they were pregnant, drug abuse, recent major trauma, etc. So looking at the provocative test, just to kind of review this for everybody, there's the thigh thrust, where the symptomatic side is the hip is flexed, the knee is flexed, and you place downward force on the thigh. The sacral thrust with the patient in the prone position and applying pressure to the sacrum. Gainsbow's maneuver, where the symptomatic leg hangs off the table with the less symptomatic leg being flexed upwards, and then you apply downward pressure to the knee. Yeoman's test for the symptomatic is once again in a prone position, hyperflex. And then the Faber or Patrick's test, which is flexion, abduction, external rotation of the hip. The distraction test, which is a decubitus position with the pressure, and then a compression test as well, which is kind of lateral, stresses the lateral motion of the SI joint bilaterally. So the way this study worked is it started with the retrospective study of 423 patients. 17 of their patients refused any treatment. 406 began with conservative management. Of those 406, 213 improved in their pain and functional status. So then that led to 193 who had no response and continued pain. And they received SI joint infiltration, and the 152 that responded positively to the SI joint infiltration then were kind of filtered into the trial, retrospectively, obviously. So 74 of these patients were basically forced to undergo conservative management because the insurance would not require or would not approve SI denervation or SI joint fusion. So this became kind of the natural history cohort. The SI and then the rest of the cohort decided between just having SI denervation or the SI joint fusion. 27 chose the fusion, and 51 chose denervation. And so then they're able to follow these patients for every 6 months, and then some patients had follow-up all the way out to 6 years. The baseline characteristics, there was no, significant difference between any of the patients in any of these groups. Now, I do want to comment that these conservative management patients were the patients that also did not improve with conservative management initially. So it's kind of the study may be a little bit flawed in that sense. One thing that they did differ in was that the patients that underwent surgery had SI joint pain duration for less years. And I wonder if this is just biased because these patients who wanted to undergo fusion earlier were just more on top of their pain and wanted to be treated quicker, rather than those that felt like they could live with it for a longer time. And as you can see, the patients who underwent SI joint fusion had a significantly less had a lower chance of having a history of lumbar fusion and a higher chance of never having any kind of surgery. So it's kind of interesting, the ones that chose surgery had no history of surgery. And I wonder if the patients that chose to have lumbar fusions in the past maybe had lumbar fusions under the guise that would help their SI joint pain, but they were diagnosed with lumbar spondylosis. And without the improvement in the lumbar fusion, they decided not to pursue further surgical management. Well, that's just, I'm speculating now. So looking at the results of the study, as you can see, prior to treatment, all the cohort was the same, and then you see the division of the cohort at treatment. And you can see that in the visual analog scale for pain, that patients that had SI joint fusion and an SI denervation immediately after following the procedure had a similar trajectory, while conservative management remained elevated and never really improved. SI denervation eventually joined and trended towards that direction. Meanwhile, SI joint fusion patients continued to have persistently low pain scales once they recovered from surgery, about a year out. Now, this looks at the Oswestry Disability Index in a similar appearing graph. You can see that SI joint fusion way out is superior to SI denervation and conservative management. Once again, SI denervation appears to just blow the smoke out of the burning building, while SI joint fusion in this series appears to put the fire out. It's one metaphor to use. So looking at opioid use over time, I found this very interesting. The patients that underwent conservative management and SI denervation had significantly higher rates of opioid usage compared to the SI joint fusion. As you can see, 2 out of 27 patients in the fusion at their last follow-up were on opioids. Meanwhile, 84% and 85% of conservative and denervation patients, respectively, were on opioids at their last follow-up. And then you look at the work status, which I find very important in telling the patient's quality of life. You can see that for SI joint fusion, that 70% of SI joint fusion patients were working at their last follow-up. Meanwhile, denervation and conservative management were 34% and 19%. So the biggest takeaways from this retrospective study is that patients who underwent SI joint fusion took less opioids by final follow-up, were more likely to be employed, experienced lower amounts of pain, and had a lower oscillatory disability index. The strengths, there's no crossover. Unlike other kind of prospective studies that allow patients to cross over, we actually can follow the natural history of the disease versus surgical history. And then there was a up to 6 year follow-up for these patients, which is a lengthy follow-up to really see how they're doing. And then data points were collected at 6 months for each patient, which allowed those beautiful line charts to really follow the trajectory of patients. Weaknesses, it's a retrospective, non-randomized study. There was difference in prior surgery for the conservative versus the SI joint fusion, and then it's a low sample size as well. Also, I'd like to add that the fact that the conservative management patients that got better initially before they were divided weren't included in the study. So that's a whole cohort of patients that's kind of missing from the initial identification of patients with SI joint pain. So, anybody have any thoughts or discussion?
Well, thank you, Matthew. That was a very interesting study, just looking at the different treatment modalities in general. Apologies for a little bit hard to hear it, but I think we heard enough to understand the at least the benefits of surgical treatment in this cohort compared to conservative treatment. Dr. Chapman kind of raised some interesting points in the panel, and I kind of want to ask him to comment a little bit on them. But just before we do that, a lot of commentary has been on the fact that, are we diagnosing this properly? Would conservative treatment, if given enough time, or better conservative treatment, just lead to improvement anyway? And so do we need surgical treatment? My issue with surgery, or my issue with conservative treatment, is that surgical treatment, at least primary surgical treatment of the SI joint, is so relatively minimally invasive. And obviously there's cost to it, but compared to broader spine surgery is relatively inexpensive. And its post-operative metrics, including length of stay and, for example, healing time and so on, are relatively so shorter. Does it make sense to pursue months-long conservative treatment and potentially spend resources in the long-term follow-up of these people treated through non-operative measures when surgery is so good? And just with that as a background, can I ask you, Dr. Chapman, your points on this diagnosis and conservative versus surgical treatment?
So I thank Dr. Helton for having brought this paper to our attention. We are strong fans of Dave Pauly, the senior author on this paper. He's here many times. He's a great mind. I am very worried about his conflict of interest potential. I'll just put it that way. I don't want to diminish the scientific basis and his accuracy as a reporter, but there is an inherent bias in him, given his role in the evolution of surgery. I could basically hit the same amount of articles back at showing that natural course history and denervation procedures have the same or better results as SI joint fusions. Again, I have a reverse bias. In my practice, I have a steady flow of patients who've had double or triple or sometimes quadruple titanium bars across SI joint and are as unhappy as anybody afterwards. So I think I'm not diminishing the role. There's clearly a not small role. My best gestalt is maybe 20–30% of patients who have true SI joint pain. Clearly what we have to do below long fusions, as Marcus has alluded to before, has to be strongly reevaluated in favor of probably including it as a fusion. But this overzealousness to do procedures in an outpatient basis does have me worried. And there's Again, a undisclosed at this point in time legion of patients who are not happy. So we're still not clear about our diagnostic accuracy, and we've over-relied on infiltration tests, which are frequently not clear in terms of how well they actually performed. Just on a side note, the SI joint is a diarthrodial. It frequently has 2, sometimes 3 different compartments. So it's not just one joint. It is subcompartmentalized quite frequently. So just a small little point about accuracy of SI joint injections. So I think there's ample of room to try to study this phenomenon better. I have no doubt that there's a significant burden of pain disease if we allow for the posterior superior iliac spinous process pain reproduction as being categorized as SI joint pain. I'll stop here. I could talk for an hour.
No, thank you. I mean, there's some really important kind of points that you brought up, each of which, again, we can talk for a long period of time. Can I ask any of the panel whether they have, from their personal experience, whether they want to comment on those important points raised, particularly with conservative versus surgical treatment? I'll just kick it off by asking you, Dr. Chapman, do you think the problem is diagnostic? Is that the issue? For example, if we were to, through radiographic means or, nuclear medicine or something, really hone down the subcategory of patients with true and isolated SI joint pain, then would surgical treatment make more sense and hence produce better results in your opinion?
I personally think that we as surgeons should kind of define what is appropriate non-operative care, what are the parameters that our patients should fulfill, what are the appropriate diagnostic injection studies that we really endorse, and then go into and as Marcus's paper had alluded to, have a far more precise imaging validation of what patients could benefit from that, seek concordance of all those spheres, and then very much promote some form of SI joint fusion or stabilization procedure.
Mm.
Yeah. If I can add to that, one of the big issues, and I agree with you, it is diagnostic. When we talk about conservative care, it really is the same conservative care if it's a lumbar spine issue, if it's an SI joint issue, if it's a hip issue. And we still don't know what it is that we are treating, whether time is actually doing it. But if it's a structural problem, we all know that tomorrow you're not going to be as healthy as you were yesterday. The structural problems get worse. And to follow up on Jens's comment about bias, I'll put my bias in this to our gait lab and what we're trying to do there, where I think we can help with the diagnosis of this. By doing gait analysis, we're trying to figure out what's going on in the lumbar spine, what's going on in the hip joint, what's going on in the SI joint, and determining which one of those pathological entities is contributing to the gait abnormality. And if we can get over that hurdle, then maybe we can jump onto what you're saying as improving therapeutic treatment intervention for these patients, whether it's non-operative or operative.
Yeah, I totally agree. I mean, that makes a lot of sense. If we don't know what we're treating, how can we be effective with respect to our outcomes? The other thing that's always struck me is that we tend to think of the SI joint as a static joint, one where there isn't much movement. Actually, it's very functional. It's clearly under hormonal influence. Obviously, it has a role in pregnancy. Relaxin is involved in relaxing those large ligamentous structures that hold it together. So there is expected movement in a life, in a life cycle. Is it so hard to believe that it is a potential it has pathological potential if it becomes more lax, or it's an issue of the ligaments that allow the joint to become more lax. So we always tend to think of it as some static joint, and so it's less mobile than the other lumbar facets. And while that may be true in terms of degrees or metric, it definitely is a functional joint. But I totally agree. I mean, I think we need to know what we're treating so we can direct treatment and expect better outcomes.
I may make one other comment at the risk of a lot of criticism on this one, but our treatment of the SI joint may have been historically very chauvinistic. I did a review of a lot of the SI joint papers from the early 1900s on, and if you look at the patient populations, other than TB and primary infection of the SI joint, it always centered around postpartum pelvic pain. And we ignored it as potentially males that were looking at spine, because we haven't had females involved in spine care to any great extent up until very recently. We've just ignored it. And maybe now we're just realizing that this is something, and you pointed out the hormonal influence on it. There's no doubt that those SI joints move.
Yeah, very good point. Well, we're going to pivot now to treatment, and in particular surgical treatment, which I hope will be of good interest to our surgical colleagues. So Dr. Afawape, our PGY2, will look at compare a couple of different treatment implants for surgical treatment of SI joint. Thank you, Dr. Afawape. Go ahead.
Thank you, Dr. Kazemi. My name is Olusoji Afawape, and I'm a second-year neurosurgery resident here at UAMS. This article is from the Extension Group in Southfield, Michigan. Title is Minimally Invasive Sacroiliac Joint Fusion Using Triangular Titanium versus Cylindrical Threaded Implants, a comparison of patient-reported outcomes. This is published in the World Neurosurgery Journal. Now, the rationale for this article stems from the fact that sacroiliac joint dysfunction is a common source for chronic low back pain. And to remedy this, we have developed a sacroiliac joint fusion, and that has proven to be both safe, effective, and has demonstrated good patient outcomes. Now, with that, there have been a plethora of sacroiliac joint implant systems on the market, and there is no current selection criteria to help guide selection in terms of which patient will benefit from one implant system. And most studies so far have, most studies published kind of tend to source one implant system, and that's the SI bone iFuse implant. And that's what this study kind of tries to address. Thank you. They're looking at, this is just a list of the different SI joint fusion implants. And this study focused on the top two of this list. This is the SI bone iFuse and the Medtronic Rialto. And the objective was specifically to retrospectively compare patient-reported outcomes who underwent SI joint fusion using the Medtronic Rialto cylindrical threaded implant versus the SI bone iFuse triangular dowel implant. Now, there's some key technical differences between these systems. With the Rialto cylindrical threaded implants, these were placed in a posterior lateral position under stereotactic guidance. So these patients required an O-arm spin for navigation. And the thought is that by avoiding the gluteus muscles, the patient has a higher chance of better outcomes because they're anticipating less pain from disruption from the by not going through the muscles. Whereas the iFuse triangular dowel implants is a direct lateral approach that's transgluteal. This is done under fluoroscopic guidance. Of note, in this article, they say they implanted 3 triangular dowels whenever the TDI was used, whereas they implanted only 2 CDIs whenever the cylindrical threaded implants were used. I said this is a single institution study. There are 4 surgeons that performed these procedures from the years 2012 to 2008. Patients included have at least 6 months of postoperative follow-up. The diagnosis for inclusion included failed conservative management for at least 3 months, positive provocative testing, lack of other radiographic lumbosacral pathology to explain their back pain. And these patients also must have undergone and had greater than 60% of improvements in their pain from SI joint injections with local anesthetics. The primary outcome measured here are patient-reported outcomes, including the visual analog scale for pain, the Osweiler Disability Index, as well as the short form 12 in terms of the quality of life. The secondary outcomes were time to and if the rate of revision of the implants, as well as perioperative data, including surgical time, estimated blood loss, as well as the length of stay. Here's the demographic data looking at the cylindrical threaded implants and the triangle dowel implants. And overall, the patient population was pretty similar between both groups. The CTI implant system had a sample size of 74, while the TDI had a sample size of 82, so it's pretty comparable as well. The male to female distribution was also comparable. It was about a quarter to 3/4 across both groups. Both groups also have greater than 60% prior history of lumbar fusion. The primary diagnosis was mainly degenerative sacroiliitis. Now, the perioperative data included here, estimated blood loss. In terms of the cylindrical threaded implants, it seems like there's about 40 cc's estimated, whereas it was 50 cc's with the TDI, but this was not significant between both groups. The one thing to note is that there was an increase in the surgery time for the cylindrical threaded implants. The same is about an hour, whereas for the threaded dowel implants, it's only 40 minutes. Now, neither one seemed to have a significant length of stay. Both stayed for about a day and a half, so to speak. Now, when you compare the postoperative outcome in patients that underwent the cylindrical threaded implants, SI joint fusion versus the triangular dowel implant, and compare their preoperative reports to their 6-month follow-up, you see that there is significant improvement in terms of their pain, disability, as well as their quality of life between both patient populations. So suggesting that SI joint fusion with either system led to significant improvements. Now, if you were to compare that improvement between patients that underwent SI joint fusion with CTIs versus TDIs at 6-month follow-up versus a year, you see that there is no significant difference between the improvements experienced by either group, suggesting that these patients, though they benefited from the SI joint fusion, there was no significant change in terms of which implant was used. Now, they also looked at the rate of revision with SI joint fusion, and they diagnosed the need for, or the indication for revision was patients who had refractory pain, as well as radiographic evidence of pseudoarthrosis, as well as haloing around the implant. And these patients, they found that patients that underwent SI joint fusion with the cylindrical threaded implant had or trended towards a higher rate of revision, as well as a shorter time to revision. So these patients required about 13 months prior to the revision, whereas those patients that underwent SI joint fusion with the TDI system had a much less rate of revision, as well as a longer time to revision, suggesting that these implants were a lot better in the long term. However, the sample size for this is pretty low, and neither one was significant per se. So overall, this paper demonstrated that SI joint fusion with either the CTI or the TDI implants results in clinical improvements both at the 6 and 12-month follow-up. There was no significant difference between the improvements experienced between either group. They did notice a trend towards increased need for revision with the cylindrical threaded implants versus the triangle dowel implants. And they also noted that operative time was also increased with the cylindrical threaded implants. Now, limitations to the study, it's retrospective, so we have no insight into how these patients were selected for either implant system. Now, though these patients in this group had pretty good preoperative baseline, and that could have precluded or precluded any their ability to assess any statistical significant difference in the postoperative outcome measure. Now, this paper also failed to discuss any postoperative complication rates, so it's still unclear if there is a difference in that regard. And also, as we've kind of been discussing earlier, they didn't discuss any, or they didn't show any evidence of SI joint fusion or discuss how they evaluated those who benefited or from the procedure. So it's still unclear if there was any significant difference radiographically, so to speak. So primarily the key takeaways, I think SI joint fusion with either the cylindrical threaded implants or triangle dowel implants does result in significant clinical improvement. There might be a increased need for revision with the cylindrical threaded implants. However, that needs to be assessed with further studies. And that's all I have. Thank you. You're on mute, Dr. Kazemi.
I'm sorry. Thank you very much. Very interesting article. I guess we put this article up there not so much to compare, one system versus another, one vendor versus another, absolutely not, but rather also to think about the anatomical approach to the SI joint as well. Does it make sense to get across the SI joint more directly from a lateral approach, if you like, versus a posterior lateral approach? Does that really make any difference? There are nuances to the technical aspect of it for sure, and there are also hazards to also avoid in both for sure. I don't know. I mean, I think that I guess the one conclusion I took was that in their respective groups, both did well regardless of what was placed there. Now, in a more nuanced, I guess if there was a greater sample size or there was a more sophisticated way of picking up failures, for example, in the longer term, could that study give us more insight? It's interesting. At least the superficial takeaway is that a cylindrical thread versus a flat surface, albeit in a triangular dowel, doesn't make a difference in terms of outcomes in that time frame and that time period.
Yeah, Dr. Kazemi, if I could make a quick point, I agree with what you were saying as far as maybe the underlying point that I'm not sure if they were trying to make, but looking at this, I was thinking, they're kind of comparing apples to oranges here. Looking at it, I don't know if it's so much, the type of implant that they're putting in as much as it was their trajectory, like you were saying. And they weren't looking at fusion. They were looking at, like Dr. Chapman kind of alluded to, yeah. They're really looking at, which is going to stabilize better over the short term. And I think that's what's actually helping with the patient's pain. So it'd be interesting because I know you and I have used the cylindrical type system in the same trajectory as the SI bone as opposed to the oblique. So it'd be really good to look at maybe if they're going to compare the different types of implants, to maybe look at it in a similar trajectory, because it looks to me like that's what they were indirectly looking at, was the trajectory as opposed to the actual implant itself.
Yeah, exactly. Exactly. Yeah, it is a different study to look at whether a cylindrical thread is more long lasting compared to a flat surface, but either way, the approach is very important here. I mean, there are hazards in the lateral approach. The superior gluteal artery, and we've encountered it, is a significant vessel there that for the most part with MIS approaches, it can be blind. So the approach is actually really important here as well. One thing Dr. Chapman pointed out in the commentary, I think is really important to point out, is the variation of Bertolotti's, which is kind of the false joint, if you like, between the transverse process of L5 and the sacral alar. We've encountered it's definitely a condition here. I've had patients who've had bilateral SI joints treated with persistent pain, and on coronal imaging, we've picked this false joint up, and we've subsequently treated it with significant improvement. So thank you for pointing that out. Our last paper is a quick one. It's if you indulge us, it's our work on just the variation of the lateral technique, and Dr. Porter, our intern, will explain that. But again, a quick little thing on a technical note. Thank you, Dr. Porter.
Thank you. So we're going to be discussing a paper published in World Neurosurgery just last month. For some reason, it's not showing me my slide anymore, my PowerPoint. I'm not sure what happened. Okay, there we go. So it's published by Dr. Kazemi et al. Here at UAMS, describing a novel lateral approach for minimally invasive sacroiliac joint arthrodesis, an assessment of the feasibility of this approach. If you can go to it's not letting me click on the slide. Okay. So the objectives of this paper were to quantify the surgical parameters involved in this approach, to describe this new lateral decubitus minimally invasive technique, and to identify imaging preoperative parameters that predict feasibility of this technique. Next slide, please. So we've talked in great detail about some of the background of SI joint pain. As was previously alluded, sacroiliitis is a common cause of low back pain, but the actual prevalence is difficult to ascertain, with some studies estimate that up to 30% of diagnoses of chronic low back pain can be attributed to sacroiliitis. However, this diagnosis can be very elusive. This diagnosis of SI joint pain is particularly common in patients who have undergone prior lumbar fusions. And also note, SI joint disease has a large economic burden due to workplace absence, decreased productivity in the workplace, with tens of billions of dollars spent annually on treatment in the US alone. Next slide, please. So historically, surgical treatments for SI joint pain involved an open approach with an incision made, as you can see here, a large incision made inferior to the iliac crest. This approach is typically performed with the patient in the prone position, and there was certainly room for optimization, because this open approach had difficult access to the SI joint and was associated with significant postoperative pain and blood loss and other perioperative morbidities. Therefore, the minimally invasive technique was developed to counter these potential complications. Also, in this approach, historically, the patients are also in the prone position. As you can see, both in the minimally invasive and in the open approach, what sticks out is the sort of awkward or unnatural angle that the surgeon is forced to utilize to insert the pins and the implants. So this is a very uncomfortable angle, and from an ergonomic standpoint, there certainly seemed a potential for improving this technique. Next slide, please. So the prone SI approach, again, with a large incision made inferior to the iliac crest, is not ergonomically sound for many reasons. As was previously mentioned, when the surgeon is applying the pins in the implant, the arm is forced to hammer in a horizontal plane, forcing the shoulder to internally rotate, the forearm to supinate, and the wrist into flexion. Again, this is not ergonomic. for the surgeon, and therefore the authors developed a lateral approach to address these issues with the same minimally invasive surgery performed, except with the patient in the lateral position. As you can see, there's a much the surgeon is in a much more comfortable position in placing the pins and screws in a much more natural fashion. Next slide, please. So just a little background on work-related musculoskeletal disorders among surgeons. So many papers have been published describing these work-related MSK disorders. There was a meta-analysis and systematic review published in JAMA Surgery in 2018 that looked at 21 articles and almost 6,000 physicians. And this study found a very high prevalence of work-related musculoskeletal disorders among surgeons, with during the study period, 12% of surgeons being required to have a leave of absence or restrict their practices or modify their practice, or even forced into early retirement because of work-related musculoskeletal disorders. And the study concluded that not only is this a burden to physically for the surgeon, in which they may be forced to modify their practice or undergo an intervention for their musculoskeletal disorders, but they also concluded that this may also contribute to a high prevalence of burnout, depression, and attrition among surgeons and interventionalists. So as such, the authors of this paper did feel it was important to address, when optimizing a procedure, it's important to address not only the outcomes for the patient, but also from the standpoint of the surgeon. Next slide, please. So I'll go into this in a little more detail, but in a further slide, but this paper involved a prospective cohort of patients who underwent minimally invasive SI joint arthrodesis in this lateral decubitus position from 2017 to 2020. Again, all of these patients underwent the procedure in the pre-COVID era. The diagnosis of SI joint pain was based on the International Association guidelines, in which require at least 2 SI joint injections under fluoroscopic guidance, resulting in at least 75% reduction in pain. And an additional criteria utilized in this study was that patients also had to have at least 2 positive SI joint maneuvers preoperatively on physical exam. Other inclusion criteria, aside from SI joint pain, include failed conservative management for at least 3 months, and imaging such as hip imaging and lower back and lumbar spine imaging that was negative for other pathologies that could contribute to their chronic pain syndrome, such as hip pain, lower back pain, radiculopathy, or any erosive or destructive lesions. Next slide, please. So here is a diagram of the positioning of the patient during this procedure. Again, very similar to the positioning of a patient in a lateral lumbar interbody fusion. So this positioning would not be uncommon to most minimally invasive surgeons, with the patient placed in the lateral decubitus position with padding between the lower extremities, an axillary roll placed underneath the contralateral arm to protect the brachial plexus. The only significant difference between this positioning and the positioning for a lateral lumbar interbody fusion would be that in this particular technique, the hips and the knees are both going to be extended. Next slide, please. And for preoperative imaging, the pelvic angle. So here's the pelvic inlet angle, and then next slide, please. And the pelvic outlet angle can also very easily be obtained preoperatively. Next slide, please. So the surgical procedure, of course, the patient is prepped and sterilely draped. one particular consideration when performing this procedure is that it is important to be cautious to prevent impingement of the L5 or S1 nerve roots. The sacral alar plate here is mapped out, as well as a superior sacral end plate, the anterior and posterior sacrum, and then a very small, about 3 to 4 centimeter incision is made just below the sacral sacral alar line, and then pins using the preoperative imaging are placed in the SI joint in the same trajectory as the final implants. Next slide.
Zach, I might interrupt. I know, unfortunately, it's been such an interesting discussion. We've got times ahead of us. Would you just go to the conclusion slide? I think that really encapsulates everything that we want to say here, and then we'll finish up. Thank you, Zach. Great presentation so far.
Yes. So in conclusion, this study demonstrated that this minimally invasive lateral SI fusion has similar outcomes to the prone approach, minimally invasive approach in terms of identifying proper pin placement, implant placement, length of hospitalization, operative time, or length of surgery, blood loss, radiation dose, etc. And so essentially, if the same outcomes may be obtained with the same accuracy of the implant placement, then why not do the surgery in the most comfortable position as possible as a surgeon? Not only may this potentially improve patient outcomes, but it may also improve long-term surgeon outcomes for the surgeon as well. So thank you for your attention.
Thank you, Dr. Porter. That was a great presentation. Again, apologies for the time period, but we just wanted to demonstrate that for the minimally invasive surgeon who employs lateral lumbar antibody fusion techniques as part of their armamentarium, this is a great way to preserve your neck, preserve your working joints, and of course, the outcomes, of course, are the same, but in a much more ergonomic position. Thank you to SSF. Thank you for allowing us to present, and we're honored to have been part of the virtual Spine Journal Club. Thank you.